Welcome on behalf of the ICC leadership. It is my pleasure to welcome you to day 3 of our great conference and the ability to learn from each other as well as from a panel of experts as we invent the healthcare system of the future. So this morning, we're going to move outside of the operating room and into the Enhanced Recovery After Surgery platform. And we have 4 presentations. My name is Tom Schwan. I'm from Corewell Health in Detroit. My co-moderators are Dr. Ortoliva from Boston Medical Center and Dr. Leila Hosseinian from Lankenau. In the spirit of trying to move things along and making sure that we meet our obligations to our speakers, we're going to change the order of presenters. So the first speaker will be Dr. Mark Ferguson from University of Chicago. He's a thoracic surgeon with a track record of accomplishment. He will talk to us on a talk entitled From Frailty to Rigorous Quantification of Frailty. Dr. Ferguson.
Thank you very much for the invitation, Tom, and to the organization. I have no disclosures. These are the learning objectives for this morning. Hopefully you'll be able to identify at least 2 methods of measuring frailty, understand how frailty impacts the results of your coronary artery surgery, and discuss mitigation interventions. As I hope most of you know now, frailty is a clinical state of vulnerability to stressors. It leads to increased dependency and higher rates of mortality after surgery. It's associated with age and is associated with poor physiologic reserve. Age is an important issue here. You can see that over the next 40 years, we're faced with increasingly aging population, and frailty increases with age, pre-frail in the pink and frail in the blue here. Frailty is associated with adverse end-of-life or late-in-life events, as you can see here. And so all these factors have influenced outcomes of surgery. This is the operative severity score related to level of frailty, and coronary artery surgery falls in the OSS 4-5 category, and the very frail patients, as you can see, have an estimated mortality rate of about 30%. Frailty increases hospital costs, direct costs, indirect costs, total costs, and decreases hospital profitability. Cardiothoracic surgery falls over here. It's not quite significant, but I think if we left out thoracic surgery, it would be another cost center that loses money in frail patients. So all these have combined to render frailty a hot topic. These are publications since 1965, read all publications in biomedical journals with frailty in the title, and in the blue is all surgical publications. If you single out publications related to CABG patients and change the scale slightly, you can see there's been an uptake in the last 4 or 5 years or so in publications on this topic, and if we change the scale again, that's almost matched by the publications on SAVR. Of course, as you probably know, this is all driven by TAVR, and it's found that frailty is a good surrogate for lack of utility of intervention in frail patients. And I think as recent as 2019, it's been mandated that frailty evaluation be performed prior to TAVR. The etiology has not really changed. Our understanding of it is that there's neuroendocrine dysregulation and aging with senescence of musculoskeletal changes, also affected by disease. And now we understand in the last 25 years or so that a lot of this is underpinned by chronic inflammation, and as you're well aware, chronic inflammation is also highly associated with cardiovascular disease. So there are different trajectories of frailty. Not all of them are immediately apparent. Biologic aging begins, but there's full compensation from phenotypic and functional standpoints. But when phenotypic aging begins, we have only functional compensation, and once we lose that, begin total decompensation into the frail state. In the cardiac surgery world, this the 3 strikes model is quite effective. Strike 1, baseline vulnerability. Strike 2, a cardiac stressor, including cardiac surgery. And then a post-event stressor, and all those lead to poor operative outcomes. So let's talk about some of the outcomes of coronary artery surgery related to frailty. This is a population-based retrospective cohort from Canada. Primary outcome was mortality. Of the 40,000 patients entered, 22% were found to be frail. This is the long-term survival comparing not frail to frail. And dividing those into age categories, you see a substantial difference in every age category in survival, frail versus not frail. The adjusted hazard ratio is highest in the young patients and is negligible in the oldest patients, 80 and above. So this is maybe counterintuitive, but would encourage us to screen even our younger patients for the status of frailty. So in summary, frailty was present and associated independently with long-term mortality. The risk of frailty-related death was inversely proportional to age, and this yields a pretty large group that's a target for frailty screening and preoperative optimization. A second study, the VA frailty study, looked at from 40 centers, accumulation of maybe 20,000 patients, and looked at adjusted outcomes, as you can see here. The frail incidence was almost 50% using their frail scale. And you can see the long-term survival outcomes here. Overall, differences, pre-frail versus not frail, frail versus not frail, and frail versus pre-frail. And that was true for most of the age subcategories. The only difference was when you get over 80 years of age, frailty is not so important anymore. It's all the other comorbidities that take their toll. So pre-frailty and frailty were very prevalent in this cohort. Frailty was associated with worse survival, and this identifies an opportunity to mitigate frailty preoperatively. So how do we identify frailty? Well, many of us tend to use the eyeball test, and that's good for differentiating vigorous patients from frail patients, but everywhere in between, there's not general agreement or accuracy in assessing frailty. And that's true whether the geriatricians were doing this or people who had been in medicine for a long period of time. So frailty needs to be measured. There are 2 major approaches to doing this, looking at phenotypic frailty, physical frailty, or deficit accumulation frailty indices. Phenotypic frailty is really a biologic system that's biologically driven to yield these phenotypic changes, whereas the risk scores come from abnormalities and observed behavior or clinical findings in patients. There are at least 100 frailty scores in existence now, so choosing among them can be challenging, and which one you choose can yield different results. This is SAVR and TAVR patients, but you get the idea that different cohorts of patients and different scales yield different results. This essential frailty tool set that's used in some TAVR studies seems to be quite useful and easy to do. A simple rising from a chair test, straightforward mini cognitive impairment test, and then some blood work. And you can see that the level of EFT score correlates very well with 1-year mortality. So how should you select an appropriate frailty instrument? It really depends on what you need it for. The physical frail scales are best for looking at immediate operative risk, and these scales also generally will respond to mitigation, so you can measure it before and after your mitigation to see how much improvement there's been. The deficit accumulation tools are more multidimensional and useful for long-term survival and long-term quality of life. If you identify frailty, generally we'll recommend a comprehensive geriatric assessment. Consider prehabilitation using these elements identified here, and use that knowledge to inform shared decision-making. We'll hear more about ERAS momentarily. So this seems to be how to understand the effects of this. A healthy patient will experience the surgical stress and then ultimately recover back to their normal original level. The frail patient will experience the stress but not recover to their normal level if they survive. The mitigation changes that risk a little bit, the stress here, but it helps the patient return almost back to their baseline level. Mitigation is done with physical activity, very strong evidence for that, and nutritional repletion. This is a study of prehabilitation in CABG patients looking at time 1 at presentation, at least 2 to 3 weeks prior to surgery, T2 1 day prior to surgery, and T4 after recovery and postoperative recovery, rehabilitation. And you can see the results of the prehab showed substantial improvement between times 1 and times 2, and that improvement differed again from control patients and persisted to time 4. So this demonstrated that short-term prehab improved prehab functional capacity and quality of life. Functional capacity and quality of life also persisted at time 4, and there were no risks to this intervention that were identified. So in summary, prehab, strong evidence for improving functional capacity, moderate evidence for postoperative complication length of stay improvements, some evidence for improved frailty score, unclear whether there's long-term improvement in quality of life. And just one brief comment about this paper from Stanford, non-cardiac surgery patients, but I think it gives a clue as to mechanisms of a relatively small number of patients. The intervention here was 2 weeks of remote individual coaching a couple of times a week, and then a lot of testing before and after. And what they showed was, and these are just samples, improvement in the wall squat test comparing personalized prehabilitation to controls, and improved mild cognitive impairment tests, same cohort. They were able to demonstrate an improvement in inflammatory mediators and a decrease in important postoperative complications with this short intervention. So in conclusion, frailty is common in CABG patients. Screening is essential for quantifying patient risk. Screening is important even in patients who you don't consider to be old. Involve a team in the assessment of these patients and attempt mitigation whenever possible. Thank you very much for your attention.
Thank you for a very good talk. We'll be having questions at the end, if that's okay with everybody. I want to introduce the next speaker as well, Dr. Liang Shen from Cornell, works in the cardiothoracic intensive care unit and is an anesthesiologist intensivist. He's going to be talking to us today about postoperative delirium and cognitive recovery and whether or not this is an ERAS oversight.
Hi, thanks for having me here today. I'm Liang. I'm an anesthesiologist and intensivist at New York Presbyterian Weill Cornell here in New York. So today I'll be talking about postoperative delirium and cognitive recovery in the context of ERAS. So we're all familiar with delirium, and this is a very common picture of a patient who's delirious in the ICU or on our floors. This picture is generated by AI, not a real patient. And she's an older patient. She looks disheveled. She looks confused, upset. She looks like she's reaching for her nasal cannula, about to pull it off. Her IV is dangling, hanging on by a thread, hanging out of her arm. And this poor nurse is trying to talk her down and trying to reassure her and trying to keep her safe. So after cardiac surgery, delirium is extremely common, and depending on the cohort that's analyzed, it ranges from an incidence of about 25% to greater than 50%. So we see this all the time, every day. How do we diagnose delirium? So the DSM-5 definition for delirium is that it's a disturbance in attention awareness developing over a short period of time with fluctuating severity and disturbance in cognition. There's 3 different types of delirium. Hyperactive delirium is what we think of when we think of a delirious patient. That's the agitated, upset patient who's pulling out their lines and medical devices. Hypoactive delirium, in fact, is probably more common than hyperactive delirium, and that's a type of delirium where the patient is actually quite often pleasant, quiet, sitting in their bed, lying in their bed. But when you actually screen them for delirium, they're extremely confused. They don't know what's happening. And then there's also mixed type, which are the patients who exhibit signs and symptoms from both hyper and hypoactive delirium. Delirium after cardiac surgery has been linked to various complications, including increased long-term mortality, perioperative morbidity, increased hospital length of stay, higher cost, and a lot of these patients actually have protracted cognitive dysfunction up to about a year postoperatively. What causes delirium? Like many of the phenomena that our patients experience postoperatively, the cause is probably multifactorial. Preoperative risk factors include commonly thought of things like frailty, older age. One of the biggest risk factors is pre-existing cognitive dysfunction of any sort. So patients who have a history of brain injury, dementia, Parkinson's disease, Alzheimer's disease, pre-existing psychiatric diseases like depression, schizophrenia, schizoaffective disorder, use of psychoactive drugs on a regular basis like alcohol abuse, and overall disease severity. Intraoperative factors that contribute to the risk of delirium include the length of cardiopulmonary bypass time, increased surgical complexity, the perfusion management, including the maintenance of mean arterial pressure during the pump run. And this is believed to be contributors because of the formation of cerebral emboli and neuroinflammation that comes as a part of the surgical process. And postoperative risk factors that can contribute to delirium include the type and the amount of sedatives that are used. In particular, in the ICU population, benzodiazepines and opiates have been strongly associated with formation of delirium. Anticholinergic medications such as diphenhydramine, Benadryl, scopolamine, and hemodynamic instability, those are all associated with delirium. Delirium has been mentioned in the 2024 cardiac ERAS recommendations. And what they said is that the routine use of systematic delirium screening tools and non-pharmacologic strategies aid in the identification and prevention of postoperative delirium with high level of evidence. What that means in real life is that before surgery, all patients should be screened for risk of delirium to identify those patients at the highest risk. Postoperatively in the ICU, delirium should be detected using a systematic delirium screening tool at least once per nursing shift. As mentioned, especially hypoactive delirium is frequently missed. So many of our patients are experiencing delirium, but we can't help them because we don't know that they have them. The two most common tools used for delirium screening are the confusion assessment method for the ICU, called CAM-ICU, or the intensive care delirium screening checklist. When we have a patient that we think has delirium, the first question is to make sure that there is no alternative organic diagnosis, like low cardiac output state, cardiac tamponade, sepsis, hypoxemia, or even poorly controlled pain. Once we diagnose that patient with delirium, the non-pharmacologic therapies are still the most efficacious and remain the first line. What that means is if that patient uses hearing aids, if they use glasses, provide those to the patient so that they can interact meaningfully with their world. Increasing mobility and rehabilitation to these patients so you can increase their functional status and improve their functional abilities. Improving their sleep and normalizing their day and night cycles as much as possible. Reducing the use of sedatives and deliriogenic medications, like we just mentioned, and encouraging family support, reorientation, cognitive stimulation. All of these therapies have been shown to be beneficial for patients who experience delirium. The pharmacologic therapies can also be considered and used for patients with distressing symptoms or posing a safety risk to themselves. So patients who are about to pull out their balloon pump, who are about to dislodge their central line, who are about to extubate. So these type of patients can be treated with typical or atypical antipsychotic medications. The most commonly used are haloperidol, Haldol, quetiapine, olanzapine, and a variety of others. It's important to note that randomized controlled trials have not found efficacy in the use of prophylactic use of various medications in these classes, as well as clonidine and some others. So it's important to note that even though we don't want our patients to have delirium, it doesn't seem to be efficacious to treat all comers with these antipsychotic medications. What about the most recent evidence, say, about delirium management? Is there anything new that we can try to offer these patients? So earlier this year, the Society of Critical Care Medicine released a focused update on their pain, agitation, delirium, immobility, and sleep guidelines. So a few notable updates about delirium are presented below. They recommend the use of dexmedetomidine over propofol for sedation in patients who are on the ventilator. This is a moderate certainty of evidence, and this was kind of upgraded from their previous recommendations. They find that the use of dexmedetomidine in comparison to propofol in intubated patients decreases delirium prevalence, decreases delirium duration, and decreases ICU length of stay. There's probably no change in mortality, no change in mechanical ventilation length, and there is probably the side effect of bradycardia, which was seen more commonly in the patients who used dexmedetomidine. There may or may not be a signal for increased hypotension in these patients as well. So consider the use of this medication. The recommendations say that we should offer enhanced mobilization rehabilitation over usual care mobilization to these ICU patients, also moderate certainty of evidence. They find that enhanced mobilization programs offer a variety of benefits to these patients postoperatively. So they definitely reduce ICU-acquired weakness, they improve functional outcomes post-discharge, they improve quality of life post-discharge, and they may improve some other outcomes such as likelihood of discharge home, length of mechanical ventilation, ICU length of stay, hospital length of stay, and delirium duration, but those were kind of small effects, and they were not quite as confident about that, looking at the literature. What about safety outcomes? So one of the common questions about enhanced mobilizations, these patients is, will they experience instability? Will they dislodge their medical devices? And they found that actually there was no increased risk of any of those outcomes except for an increased risk of arrhythmias. But all the other safety outcomes were actually the same as usual care. The recommendation also says for this particular point that the data that they analyzed was insufficient for subgroup analysis of cardiac surgery patients. But because the randomized controlled trials that they were analyzing this recommendation tended to include previously functional patients, it's probably, I would say, extrapolatable to our patients in cardiac surgery. And finally, the last thing they said is that you can consider the use of melatonin to improve sleep in these patients. This was low certainty of evidence. They find that the use of melatonin probably reduces the risk of the prevalence of delirium and improves patient perceived sleep quality. But interestingly, the total amount of measured nocturnal sleep probably doesn't change, and it probably doesn't change delirium duration for those patients who already have it. So because of the fact that there is possible benefit to using melatonin and because there was no increased signal for increased risk, they thought that that was a reasonable thing to do in ICU patients. So in summary, delirium is very common after cardiac surgery. We need to use a systematic approach to detect and diagnose this disorder because many times it is missed, and we cannot help our patients if we don't know what problems they have. Non-pharmacologic therapies should be maximized for all of the patients at risk for delirium. Antipsychotic medications can be used judiciously in select patients who exhibit safety concerns. And we can consider the use of adopting dexmedetomidine over propofol for patients who are on the ventilator and require sedation, using enhanced mobilization programs for ICU patients, and consider melatonin for sleep. Here are some of my references.
Thank you.
Thank you.
Thank you for that talk. We're going to move on to the next one. We'll leave questions for the end. The next talk is by Marta Kalava. She's a cardiac anesthesiologist at the Cleveland Clinic. She's going to be speaking to us about opiate-free recovery in cardiac surgery, vision or viable.
Thank you. Thank you for the kind introduction, and thank you for the invitation to deliver this talk. Now, we all know that cardiac surgery, cardiac anesthesia, demands the very best of us, physically, emotionally, technically. But even when the cases go perfectly well, something as simple yet as complex as pain management can derail patients' recovery. And this is why the topic of my today's talk is whether or not we should try to do an opioid-free recovery, and what does the research, what does the data show about that? Can this be a new evolution in pain management for our cardiac surgical patients? I have no disclosures relevant to the talk. Now, we all know that most of our patients still experience very opioid-heavy recovery, and with that come predictable complications. Despite receiving opioids, I'm sure each and every one of you here have had a patient who still reports pain to be 10 out of 10. So all of these issues derail patients' recovery. They slow the healing and they reduce their quality of life. So the question is, can we do better than what we're doing now? Now, cardiac anesthesia has traditionally been relying on high opioid doses. In the past, we called cardiac anesthetic as opioid-free anesthetic. And over the years, the doses used intraoperatively and postoperatively have dramatically reduced. Yet, the opioid-first culture for postoperative pain management persisted. Now, I want to digress a little bit and make you think about some definitions. If you ever thought about what is pain, there is an actual international definition of pain. And it states that pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So essentially, pain is an emotion. And if to a group of non-anesthesiologists, what is anesthesia? Several components: hypnosis, amnesia, analgesia, and muscle relaxation. And a question for you, can we do anesthesia without muscle relaxation? We certainly can. Maybe not in cardiac surgery, because you guys are always going to complain about diaphragm moving, but in other surgeries, we certainly can. Another more debatable question is, can we do anesthesia without analgesia? And what are we actually treating with opioids intraoperatively? If you ask, most of my colleagues are going to say, well, we're treating pain. Then when you present them with an international definition of pain, they realize, okay, we can't really experience pain while we're under anesthesia. There is nociception, there is a completely different concept, but not pain. So the next answer you're going to get, well, we're treating surgical stress response. So what is surgical stress response? Surgical stress response has two main components. One is the neurohormonal response, the other one is immunological response. Within the neurohormonal response, we have activation of the sympathetic adrenomedullary system with subsequent increases in catecholamines, hypertension, heart rate increases, hyperglycemia, all these things. And then we also have activation of the HPA axis with subsequent increase in cortisol release. On the other side is the immunological response, which is in summary characterized by increased systemic inflammatory response followed by a compensatory non-inflammatory response. So should opioids be the go-to therapy for surgical stress response, considering all the downstream harm that they're associated with? And I will dare to go even a step further and ask you, should we even be blunting the surgical stress response altogether? And I'm sure each and every one of you in this room are not sitting here because you've avoided stress all of your life. Rather, the key is to find a balance. So I'll give you a simple example in anesthesia. You may or may not be familiar with etomidate. It's a commonly used induction agent. A lot of anesthesiologists are backing away from etomidate. They're not using it anymore. Why? Because after years of using it as a primary sedative in the ICUs, we found that etomidate is associated with increased morbidity and mortality in our patients. And why was that? Because it reduced cortisol secretion. So essentially, etomidate as an induction drug blunts the stress response and causes increased morbidity and mortality. So something seems to be wrong here when we talk about blunting the stress response. Moving on to opiates that we use for you're probably familiar with all of them. Bottom line is that all of them have same mechanism of action, mu-opioid agonism. They are different in potency, metabolism, but essentially they all do the same, and thus they all have the same side effect profile. I do want to highlight methadone because it also has an NMDA antagonistic effect. And why is that important? Because it is relevant when you talk about concepts of opioid-induced hyperalgesia, because NMDA receptors are extremely important in that aspect. So with opioids come two issues. One are opioid-induced hyperalgesia, and another one is opioid-induced tolerance. So basically what that means, in a nutshell, you give opioids, they have their effect, But there is internalization of receptors, so basically there is loss of receptors, which means that you have to give more opioids to achieve the same effect. With the hyperalgesia, it's a little bit different concept. At the level of the spinal cord, you basically have hyperamplification of the pain signals as a result of giving opioids. So this is why you'll always have patients who are never going to get comfortable and who always require more and more opioids. So what does the research show? There is absolutely not a single trial in cardiac surgery examining opioid-free anesthesia that I can report here. However, there are multiple trials in general surgery literature that suggest that when you use no opioids intraoperatively, postoperatively you achieve improved pain control and you have reduced side effect profiles from the opioids. There was a meta-analysis published in 2022 with over 6,000 patients, granted including mostly minor procedures. But what they found is if you discharge patients on opioids, your pain control is not going to be any better. However, you're going to have almost 5-fold increased risk of nausea and vomiting. And if you've ever experienced nausea, I'm telling you, it's way worse than pain. Now, what is happening in the literature still, we have one trial that is happening in France right now. They are using 4 institutions and comparing opioid-free anesthetic versus opioid anesthetic in about 300 patients. So we'll see what that trial shows. That's going to be the first step towards proving this concept. So if not opioids, then what? The solution is multimodal approach, which entails use of non-opioid agents and regional anesthesia. It has been supported by Eros Cardiac Society with a moderate level of evidence. And this is what we have in our multimodal toolbox. These are the medications that we can use intraoperatively instead of opioids. I want to spend a second on methadone as an opioid that I personally use in my patients as a single dose, and I've changed my practice based on these 2 trials that are a decade apart and that have suggested that if you do a single dose of methadone intraoperatively, patients have reduced opioid consumptions postoperatively and improved pain. And I've seen that in my patients. They're comfortable for at least 24 hours when the pain is worst after they receive a single methadone dose. So I cannot answer this question yet. More data is needed for me to definitively say that we can do cardiac anesthesia, at least intraoperatively without opioids. But this is how my ideal pathway would look like. First, preoperative education is extremely important because if you remember, pain is an emotion, and emotion can be influenced by priming the patient to what the expectation should be. Baseline use of acetaminophen, Tylenol, around the clock for all of our patients, and then intraoperatively simply using all of these multimodal medications that can help with reducing hyperalgesia and improving postoperative pain management. And then post-op, try to stay away from opioids. Have scheduled non-opioids, brief adjunct infusions such as dexmedetomidine or ketamine if needed, and then give opioids only as a rescue. And of course, try to discharge patients without opioids. So opioid-free anesthesia may be the next evolution in postoperative pain, but it certainly makes mechanistic sense. However, we certainly need more data to inform this new and novel concept in cardiac surgery. Thank you.
May I make one very, very quick comment? So
Sure.
Thank you for an excellent presentation. But what we're all missing, I come from Glasgow, and we had a population of people who are heavy alcohol intake. And the best way to control a patient post-operatively, and the safest way to do it, is a small amount of intravenous alcohol. It doesn't have all the opioid effects. It doesn't have all the negative long-term effects. And I can tell you, if you haven't done it, unfortunately in the UK, it became politically incorrect to do this. But if you want to control a patient post-operatively, make them feel happy, sedated, and they're going to get on with their recovery, the safest, best way to do it is a small amount of intravenous alcohol. Thank you.
Are you advertising Scotch?
Yes, I am.
I would say Precedex is very similar in terms of the way that I see it work as maybe the pharmaceutical way of doing IV alcohol, in the sense that it's a nice low-dose infusion, and it kind of just chills them out enough that they don't care about it, in a
And
similar
it
type of way.
avoids all the terrible effects of opioids. So if you haven't done it, small dose of alcohol, and if the patient's alert and awake because they've had minimally invasive surgery, say to them, drink it. They'll enjoy it even more.
So I'm honored to introduce Dr. Thomas Schwann. He is a cardiac surgeon and the regional chief of cardiac surgery at Corewell Health. He'll be talking to us today about anemia and blood transfusions.
So good morning, ladies and gentlemen. It's a pleasure to be here among such great luminaries of cardiac surgery. So my talk today is anemia and transfusion, or the subtitle would be damned if you do and damned if you don't. So I have no disclosures. Just to briefly review the physiology, why are we talking about this? Well, because red blood cells and hemoglobin are an active participant in the oxygen transport from the atmosphere to the mitochondria. And just to review some physiology from our medical school, oxygen delivery is calculated as cardiac output times the arterial content, and the arterial content in turn is a function of hemoglobin. So in a normal individual, normal weight, the oxygen delivery is about 1,000 cc's per minute, and the normal oxygen consumption is about 250 cc's per minute. So there's a lot of redundancy such that oxygen delivery is about 5 times higher than what is required by the body. Now, anemia, preoperative anemia, is relatively common in our patient population. Anywhere between 16 to 54% of cardiac surgical patients have World Health Organization defined anemia. And what's interesting is that in the United States, about 65% of bank blood in the US is used in cardiac surgery. And as you can imagine, the risk of transfusion increases with worsening anemia preoperatively. In our own experience, if you come to the operating room with a hematocrit of greater than 32%, the transfusion rate is about 23%. If that hematocrit in the operating room is less than 28%, that transfusion rate rises to about 83%. So there is robust data to document that preoperative anemia in cardiac surgical patients is associated with both increased perioperative and long-term morbidity and mortality. And the mechanism behind this finding, whether it's associative or causative, is at the present time unclear. We got into this business about 25 years ago. We got interested in looking at the effect of intraoperative anemia as documented by the nadir hematocrit on cardiopulmonary bypass. And what you can see in the left panel is that as the nadir hematocrit dropped, the observed complication rate for every single perioperative complication increased dramatically. And in the case of coronary surgery, as the intraoperative anemia worsened, the observed mortality rate increased, and more interestingly, the observed to expected ratio, or adjusted operative mortality, also increased significantly. So I think that we can answer this question, do we need to avoid anemia intraoperatively during cardiac surgery? The answer is an absolute yes, but the question is how to do this. And what I would like to do is to spend the rest of the presentation to convince you that transfusions are not the answer to this conundrum. So there have been at least 3 or 4 randomized comparative trials, large studies, that showed that a restrictive transfusion strategy was equally efficient to a liberal transfusion strategy with less blood transfusions, but a lower hematocrit. So perhaps less red blood cells is more. There is some interesting data that comes to us that even 1 unit of packed blood cells, this is from the Maryland Collaborative, even transfusion of 1 unit of packed cells is associated with increased perioperative mortality. And using the national database, the STS database, Dr. Girardi found that and confirmed those results in a national study that showed that operative mortality increases with 1 unit of blood, and all of the perioperative complications likewise are increased in a risk-adjusted fashion. This is data from Dr. Ferraris that interestingly shows that the risk of transfusion is highest for mortality among those patients who have the lowest predicted mortality for that index operation. And what's interesting is that as that mortality rate risk increases, the risk of transfusion perhaps decreases, which is an interesting observation. Our group and the group from the Cleveland Clinic looked at the effects of transfusions on long-term mortality in CABG patients. So on the left-hand panel here, you can see that the survival rate of patients who were transfused is significantly worse than those patients who are not transfused. This is risk-adjusted, and what I will also point out to you is that those survival curves continue to diverge, suggesting that this is an ongoing effect as opposed to just a perioperative effect. And the Cleveland Clinic group showed that this survival risk is actually increased and is dose-dependent. The more transfusion, the worse the survival. A few years later, both of our groups looked at the interaction between anemia and packed cell transfusion, and what we found was that anemic patients who were not transfused for whatever reason had a better long-term survival than those anemic patients who were transfused. We also looked at over 500,000 patients in the STS database. These were Medicare patients, and we linked that to the CMS database. And what we found that even in patients who had severe intraoperative anemia with a nadir of 18% in terms of hematocrit, those patients who were not transfused had a much better long-term survival than those patients who were transfused. And we were unable to identify any level of anemia for whom a transfusion actually improved life expectancy. And the same thing is true if we look at perioperative risks of perioperative complications. Anemia increased those complications, but anemia and transfusion was worse than anemia alone under those circumstances. So I think as this chart sort of suggests, we need to operate in the safety zone between anemia on the one side and transfusion on the other side. And how do we do this? I think that the answer to this is a comprehensive institutional blood management program anchored around a multidisciplinary team committed to minimizing anemia and minimizing blood transfusions. The STS has put out some interesting guidelines for consideration, including preoperative screening. Those patients who are preoperatively anemic should potentially be considered for administration of intravenous iron as well as erythropoietin-stimulating agents. We should minimize phlebotomy through judicious blood checking. We can look at potentially doing retrograde autologous priming as well as reducing of the priming solution for our pumps, all in an effort to decrease the amount of hemodilutional anemia. I think this is a very interesting study from the Cleveland Clinic. It's entitled Contemporary Bloodletting in Cardiac Surgery, and these investigators found that through phlebotomy in the perioperative period, approximately 1 to 2 units of cells are lost in phlebotomy. In addition, I think that we should move away from using just a simple hematocrit, a hemoglobin, as a trigger for transfusions, and we should go to a physiologic assessment of whether the patient might have end-organ ischemia or end-organ dysfunction based on decreased oxygen delivery. And some of those parameters are things such as low SVO2 if the patient has a SWAN, rising creatinine, rising lactates, etc. And with this approach, the investigators found that they can reduce the blood transfusion rate from about 56% down to 25%. And again, I think we should all be cognizant that a blood transfusion is a liquid transplant, that we should treat it as such. And finally, this is an interesting emerging concept called ultra-permissive anemia, whereby these investigators from Maryland looked at potentially not transfusing patients even with a hemoglobin of 6. And what was found is that this was to be safe after cardiac surgery and associated with reduced transfusions and excellent outcomes and significant cost savings. So the question is it the patient or is it the surgeon that can't tolerate anemia? So I will close with the following conclusions. Number 1, preoperative anemia should be identified and corrected if possible. Number 2, intraoperative and postoperative anemia should be avoided and corrected, but not through transfusions. Red blood cell transfusions are associated with increased mortality at all levels of anemia. Obviously, there is a level of anemia for which transfusions are possible, and I will stress, obviously, this is for non-acutely bleeding patients. And then finally, a comprehensive blood management program to avoid anemia and minimize transfusions is imperative to be able to avoid both anemia and transfusions. And with that, I thank you for your attention.
Tom?
Sir.
Fantastic presentation. Just one very brief, quick question.
Sure.
When
Here it
you
comes.
give these transfusions, maybe all you're doing is identifying patients who are sicker, less well, for whatever reason, and that's why they are anemic. So it has nothing to do with a blood transfusion. So my question is, by giving a blood transfusion, are you essentially identifying patients who are sicker and less well?
Dr. Taggart, always an insightful question, and I think that we've been struggling to try to identify whether it's the blood transfusion or a higher risk for patients. So we try to risk adjust these patients that we've looked at. We have also looked at a study where we looked at patients who had no other perioperative complications. They only got a blood transfusion, so no AFib, no renal failure, no prolonged ventilation. We eliminated all those complications perioperatively, and blood transfusion was still associated with negative outcomes in terms of mortality in the perioperative period. But yes, it is a struggle, and I think that we need to use it judiciously. But I think that all dogma to transfuse folks just based on a level of hematocrit is probably inappropriate. Thank you so much.
Just one other question. So when we talk about, because anemia is not just an issue for the surgeon, the patient, it's also a big issue for the intensivist, because we're the ones who are getting criticized all the time
Yes.
for the blood draws and the volume and the question that I have is, one of the very simple things that we can do is use those smaller volume vials. I mean, nowadays we can even with a drop of blood get so many labs, but I don't know of one hospital. I mean, when I have a Jehovah's Witness, I still have to work hard to get those vials. Do you know of any hospitals that really have instituted this and have moved in terms of cardiac surgery to changing all their labs and using a lot less blood?
Yeah, so again, good questions, and we are obviously at the mercy of, saving a penny versus trying to save a dollar. And, unfortunately, there are points of care platforms that you can utilize, a drop of blood as opposed to sending a vial of blood to the laboratory. These things, cost per test are higher, but nobody has ever done a quantitative long-term analysis of what the costs are cumulatively across the episode of care. So I think that there are going to be significant changes in the upcoming near future, but I have not been able to impress on our administration that this is an important step forward. Thanks. Okay, our next speaker is going to be Dr. Jamal Ortoliva, and he will give us some financial impact of the, not only of the financial impact, but also the clinical impact of the entire enhanced recovery after surgery bundle.
All right, thank you very much for the invitation. And I'll be talking about ERAS dollars and cents. I have no disclosures. And just a brief outline here, we'll introduce ERAS. It's already been introduced quite effectively, obviously. We'll talk a little bit about data specifically as it applies to CABG. We'll talk about a meta-analysis as well, and we'll talk about just applicability of why ERAS makes sense. We'll talk a little bit about cost analysis. Cost analysis is going to be spoken about in general terms here. We'll circle back to ERAS again, and then we'll conclude. So just introducing the concept as it already has been, enhanced recovery after surgery pathways for patients undergoing CABG can really improve outcomes through incremental gains. And this is the whole idea that the whole is really more and greater than the sum of the parts. ERAS protocols continue to be underutilized in this population. We'll talk a little bit about that. Mounting evidence exists that outcomes are improved in this population, including things like length of stay, duration of intubation, intensive care readmission as well. And these benefits really do translate into cost savings. Let's start out with a retrospective review, of about 1,100 patients undergoing CABG at a large center in France. So from this population, they looked between January of 2015 to essentially about the end of 2020. And they implemented an ERAS program for cardiac surgery starting in November of 2018. They found a number of outcomes associated with the implementation of this program that were improved. While their in-hospital mortality and 3-year mortalities were not different, the important outcomes that they found that were better were that they decreased mechanical ventilation duration by about 50%. They reduced length of intensive care unit stay by about a quarter. They reduced length of hospital stay by 10%. There was less pneumonia, less ARDS. There was less blood transfusion, and there was actually about a 2/3 reduction in delirium as well. So this sort of bundle package that they put together really sort of improved outcomes for their specific institution. This is from that same study that they looked at. This was published in JTCVS about a year ago, by the way. And in this table, you can see the number needed to treat for some of the interventions that they did, assuming that their ERAS program really was the main driver for kind of why these things occurred and why the improvements in outcomes occurred. Let's look at another retrospective review taken from a slightly different angle. So this is done from Hartford, Connecticut. And basically what they looked at was they also implemented an ERAS program for their cardiac surgery program. And this was, again, specifically for CABG patients, because that's really our focus here. Looking at this, they had basically about 656 patients that were not associated with the ERAS program before its implementation from 2016 to 2017. A few years after that, they had about 1,080 patients, and they even included a washout period to get used to their new ERAS program of about 6 months. Not only did they find an improvement in hospital length of stay, as well as sort of some marginal gains with regard to duration of kind of intensive care unit length of stay and otherwise. But when they looked specifically at the non-white kind of minority populations, they actually found that some of those healthcare disparities that sort of are obviously coming to increased attention, particularly in the United States, have started to go away. They also had a significant reduction in ICU readmission, which is a really important marker for adverse outcomes. This is a really busy slide. What I really just want to impress upon you here is that even with propensity score matching that they performed in the sort of specifically in the minority population, they found that they were able to reduce morphine equivalents by post-op day 1 and 2 by 30%. Ketamine in commensurate fashion sort of went up by about 30%, and that probably explains that. And they also reduced their ICU length of ICU readmission rate by an absolute value of about 7%, although small readmission rates all around. This is a meta-analysis, and we're departing a little bit specifically from ERAS to CABG. This is actually ERAS for cardiac surgery. And this was published actually this year in July. And this is, I think, an interesting sort of work because it does a couple of things. One is it compares ERAS to sort of more conventional sort of approaches to cardiac surgery, but it also looks at ERAS and compares it to fast-track extubation programs. What did they find? They found that ERAS reduces length of stay. They found that ERAS protocols are also better sort of for ventilation time. But interestingly enough, in comparison to fast-track extubation programs, which would sort of be deconstructing the ERAS program into one specific intervention, they actually found that there's a reduction in length of stay by about 2 days compared to fast-track sort of extubation programs particularly. Again, I think this drives home the point that ERAS really is showing that the whole is better than the sum of the parts. So ERAS cost analysis for CABG specifically, this is a little bit challenging. There are some small retrospective reviews that sort of discuss this. But if in fact we can reduce length of stay by a day, then yes, you're very likely to save thousands of dollars sort of just by that one intervention. But I think beyond that, with incremental and marginal gains, you can also reduce delirium incidence, pneumonia, mechanical ventilation time, acute kidney injury, and ICU readmission rate. And these are billion-dollar problems in the United States alone, let alone in the entire world. This here is just reinforcing the point that ERAS really is just common sense. So this is a study by Dr. Grant and some of the other folks from Johns Hopkins University that was published in the JTCVS in 2020. They looked at 7 process measures, and these were predominantly intraoperative, and we're slightly departing from CABG here, but it's still related to cardiac surgery. The 7 interventions mostly were pretty straightforward to perform. They involve things like Tylenol use, gabapentin use, ketamine, Precedex use. These are intraoperative interventions, as well as regional anesthesia. And then the other 2 process measures that they looked at were basically low tidal volume ventilation in the operating room, in addition to immediate reversal of neuromuscular blockade at the end of the procedure. They separated a group of 451 patients into 0 to 4 process measures followed and 5 to 7 process measures followed. And they found that the patients that had more of these process measures followed actually had a reduction in time to extubation. Their length of stay was reduced as well, and even their sort of floor admission time was also reduced. What's interesting is their ICU admission time may not have actually been decreased. However, you're seeing this on the back end when you perform these interventions early. This is a very busy slide. The point of why I'm sort of showing this to you, this comes from that study from France, the original 1,100 patient CABG sort of study. And really, I like the way that they broke up their protocol. They're sharing it sort of with everybody. They have preoperative, intraoperative, and postoperative protocols. And your protocol, if you decide to implement this, is probably going to depend on what you've been doing, what you feel you need to improve on, and kind of what new sort of interventions that you want to add to what you're doing. But I want to just show this sort of as a nice potential template of a way to sort of systematically break this up. So just concluding here, so there is emerging data. We certainly would like to see randomized data, but particularly for the CABG population, there's emerging data that suggests that ERAS can sort of provide important gains in cardiac surgical patients, and specifically the CABG population, even for the non-urgent, non-emergent CABG population. Even without mortality benefits, there are other very important outcomes that really can be improved with the use of ERAS. Shorter length of stay also means that you can do more procedures, that you can take care of more patients, you can help more folks. And if, in fact, it is the case, it would be really nice to see that an ERAS program can, in fact, address healthcare disparities, which continue to exist and in some sense even are widening. From that meta-analysis I showed you, again, ERAS is really a testament to the idea that the whole is greater than the sum of the parts. And I think that that's really the biggest sort of take-home message here. And it really can, and I think that it does, and it will be shown with more and more data that ERAS not only improves outcomes, but it also sort of reduces cost, which is an ever more important issue. Thank you all for listening. I really appreciate it.
So thank you very much for everybody's attention. We're half an hour behind schedule, so probably no chance for questions. We'll move on to the next session. Thank you very much.